Picture this. You're standing right there at the bedside. Your hand presses firmly into the patient's left upper quadrant, and you feel it, a distinct, substantial mass. Instantly, your clinical instinct fires up, and you think, ah, okay, an enlarged spleen. But hold on a second. You adjust your hand. You realize you can actually get your fingers above this mass. You tap it, and instead of a dull thud, it's resonant. Well, you've just caught yourself right before falling into one of the absolute most classic diagnostic traps in medicine. You aren't feeling a spleen at all. Welcome to our explainer today on adult polycystic kidney disease. We are going to break down the mechanics of a disease that completely reshapes the body, and we're going to do it straight from first principles. So, how do we avoid falling into that classic physical exam trap? We really have to confirm what organ we're actually touching. Let's look at the kidney first. An enlarged kidney is ballotable, and crucially, you can get above it. There's a clear physical space between the mass and the costal margin. Plus, because overlying bowel gas sits just anterior to it, percussing it gives you a resonant note. Now contrast that with a spleen. A spleen enlarges directly from beneath the costal margin, meaning there is absolutely no space to get above it. It has a palpable notch on its medial border, and if you percuss it, it's predictably dull. Nailing this clinical distinction is your essential first step.
All right, let's dive into our roadmap for today. We're going to build our understanding of ADPKD from first principles by looking at 1. The mechanics of cyst growth, 2. Vascular compression and RAAS, 3. The systemic nature of the defect, and 4. How we block vasopressin. Starting off with part 1, the mechanics of cyst growth, looking at the core genetic defect. So what's actually happening on a cellular level? Well, ADPKD is an autosomal dominant disorder, and it's primarily caused by mutations in the PKD1 or PKD2 genes. Now, these genes encode proteins that are absolutely critical for normal tubular epithelial structure and signaling. When they mutate, the nephron starts forming these fluid-filled cysts. But here is the most crucial takeaway. These cysts don't just sit there. This is a highly active, progressive enlargement that happens over decades. It's not just some static structural abnormality the patient is born with. It is a relentless, active process that steadily compresses and literally destroys the surrounding functional kidney tissue. Understanding that this is an active, ongoing process is exactly why our modern management is so hyper-focused on slowing it down. Now, this next part is super important. Because we have to account for normal aging, our diagnostic threshold actually shifts based on the patient's age. Take a look. If your patient is under 30, you only need 2 cysts total to confirm the diagnosis. But jump down to age 60 or older, and suddenly you need at least 4 cysts in each kidney. Why the big change? Because simple, sporadic cysts become increasingly common in the general population as we get older. So finding a couple of cysts in a 25-year-old, that carries massive diagnostic weight. Finding those exact same cysts in a 65-year-old, that might just be a completely normal part of getting older. As you can imagine, these growing cysts don't just sit there quietly. They cause real problems, with the most common presentation being loin or abdominal pain. But you can't just treat pain as a single generic entity here. There are 3 genuinely distinct mechanisms driving this pain. First up, cyst hemorrhage. The blood vessels surrounding these rapidly growing cysts are incredibly fragile and they are very prone to bleeding. Second is nephrolithiasis, or kidney stones. These are way more common in ADPKD because the distorted anatomy creates urinary stasis. And third, for that exact same reason, stagnant urine creates the absolute perfect environment for urinary tract infections. Distinguishing between a bleed, a stone, and an infection is vital because your clinical response, whether that's simple analgesia, antibiotics, or surgical stone removal, is completely different for every single one. Moving right along to part 2, vascular compression and RAAS, the local knock-on effects. So how does a growing cyst lead to high blood pressure? It's actually a fascinating mechanical chain reaction. Step 1, the cysts enlarge. Step 2, as they take up more and more space, they physically compress the surrounding renal blood vessels. The kidney then misinterprets this mechanical compression as a state of low blood flow. That triggers step 3, the activation of the renin-angiotensin system, or RAAS. And this chronic pressor response leads directly to step 4, secondary hypertension. It's a beautifully logical cascade, and it tells us exactly how we need to treat the high blood pressure. This is precisely why ACE inhibitors and ARBs are the first-line antihypertensive choice for these patients. They directly target the exact physiological mechanism that's driving the blood pressure spike in the first place.
But hey, hypertension is absolutely not the only reason an ADPKD patient might complain of a headache. While secondary hypertension is definitely the most common cause, we have to take recurrent headaches incredibly seriously here. Why? Because roughly 5 to 10% of ADPKD patients actually have a cerebral berry aneurysm. That is a massive association. Now, you don't screen everybody, but you absolutely must screen specific high-risk groups using an MRA. You screen if there's a family history of aneurysms, you screen if they have concerning symptoms, you screen patients in high-risk occupations where sudden incapacitation would be catastrophic. Think of a commercial pilot or a bus driver. And crucially, you screen them before major elective surgery or before starting anticoagulation, because an undetected aneurysm in those specific scenarios drastically raises the stakes.
Which brings us to part 3. A systemic genetic defect looking way beyond the kidney.
You see, those PKD1 and PKD2 genes, they aren't just chilling in the kidneys. They're expressed all over the body, meaning the structural and signaling defects are going to show up wherever those proteins function. These defects manifest as a really wide array of extrarenal issues. Hepatic cysts are overwhelmingly the most common, showing up in up to 70% of patients. But you also see colonic diverticulosis and abdominal wall hernias, which point to a much broader issue with connective tissue integrity. That same connective tissue weakness even extends to the heart, causing mitral valve prolapse. And, of course, the intracranial aneurysms we just talked about. A truly thorough clinical assessment of ADPKD genuinely requires examining the entire patient, not just their abdomen.
Now, here's a totally fascinating quirk of the disease you might actually spot on their baseline blood work: an elevated hematocrit. Normally, as kidney function declines in standard chronic kidney disease, patients become anemic because their failing kidneys stop producing erythropoietin. But in ADPKD, you can actually see a paradoxical increase in red cell mass. Why on earth would that happen? Because the cystic tissue itself can actively produce erythropoietin. It drives up red blood cell counts even while overall renal health is failing. It's a key clinical finding that perfectly highlights the unique, highly active nature of this cystic tissue.
All right, before we get into the really exciting treatment stuff, we need to soberly raise the stakes for a second. 50 to 75%. That is the massive percentage of ADPKD patients who will reach end-stage renal disease by the age of 75 if they don't get effective intervention. This is not just some benign structural curiosity we're dealing with. It is a progressive, life-altering diagnosis that comes with a very high risk of eventually requiring dialysis or a kidney transplant. Okay, let's talk solutions in part 4. Blocking vasopressin to slow growth, and how this has completely transformed the management landscape.
For literally decades, managing this disease was just passive monitoring, waiting and watching. But following the landmark KDIGO 2025 clinical practice guidelines, the focus has completely shifted to active disease modification. The absolute hero of this new era? Tolvaptan. Tolvaptan is a vasopressin V2 receptor antagonist. Remember earlier when we talked about how cysts actively enlarge? Well, vasopressin is a key signal that drives that fluid secretion and cyst growth. Tolvaptan steps right in and directly blocks that specific signaling pathway. It's now recommended for adults with an eGFR of at least 25 who are at risk of rapidly progressive disease. It's a real game changer. But look, you absolutely cannot just hand someone a script for Tolvaptan and say, see you later. The patient counseling for this drug is intense, and it's mandatory. Because it blocks vasopressin, it causes a profound and immediate increase in urine output. I mean, a lot of urine. Patients must perfectly match this with their water intake to avoid severe dehydration. They might also see an early reversible rise in their creatinine levels. There is also a very recognized risk of drug-induced liver injury, meaning structured, regular monitoring is completely non-negotiable. And finally, every single patient needs a sick day plan. Basically, if they get a stomach bug and can't keep water down, they must know to hold their Tolvaptan doses to avoid dangerous volume depletion. The KDIGO 2025 guidelines actually draw a really hard line on what we should and shouldn't do here. On the recommended side, we've got ACE inhibitors and ARBs to tackle that ROS-driven hypertension. We have high water intake. We're talking 2 to 3 liters daily because drinking lots of water naturally suppresses vasopressin release, doing a very similar job to Tolvaptan in slowing cyst growth. And, of course, Tolvaptan itself. But check out the not recommended side. No MTR inhibitors, no statins, no metformin for slowing progression, and, most surprisingly,
no SGLT2 inhibitors. Now, while SGLT2 inhibitors are amazing for protecting kidneys and other diseases, in ADPKD, their diuretic effect can actually cause the body to raise vasopressin levels. That works directly against literally everything we are trying to achieve with tolvaptan and water intake. It's just a fantastic example of why we have to truly understand the first principles of a disease.
So let's bring this whole thing right back to the bedside where we started. The next time your hand finds that mass in a patient's flank and you confirm it's ballotable, it's resonant, and you can get above it, I want you to stop and think. Are you really just feeling an enlarged kidney, or are you actually palpating a systemic genetic cascade that is quietly remodeling their liver, their brain's blood vessels, and their heart? A cascade that is actively destroying functional tissue day by day, but one that we finally have the tools to actively slow down? Understanding the mechanics truly changes everything. Thanks so much for joining us for this explainer.